We move on to the next talk by Dr. Upendra Kaul, Emerging Evidence of Oral Antiplatelet Drugs in Acute Coronary Syndrome.
Yeah, actually, Dr. Kaul was not able to come.
You are giving his talk.
So Dr. Ajit
Mullasari will
gracefully
be giving the
accepted to
talk.
present the data. Thank you, Ajit.
Thank you. I would like to thank the organizers to give me this opportunity to present emerging evidence of oral antiplatelets in ACS. So, we know what acute coronary syndromes are about, and we know the therapeutic approaches include invasive procedures, acute and secondary prevention. We also know that antiplatelet therapy is the cornerstone of acute and long-term management. The issues are that we know clearly the current standard of care of aspirin and clopidogrel for up to 1 year, but the treatment beyond 1 year has not yet been investigated. We also have some limitations of current oral antiplatelets, and that became the rationale for the Plateau study with the new drug ticagrelor. And the clopidogrel we know has large variations in platelet responses inhibition. It requires metabolic activation, suboptimal onset of action for acute settings. And as Nakul said, in current OASS 7, there is no net benefit and a raised risk of bleeding by increasing the dose, and Gravitas showed that there was no clinical benefit by doubling the dose in hyporesponders. Similarly, with prasugrel, triton showed some limitations of ACS with PCI. Though it resulted in lower MI and stent thrombosis, there were contraindications in subgroups. Obviously, there was net clinical benefit in diabetes and STEMI subgroups, but obviously also there was an increased risk of major bleeding, including life-threatening bleeding in ACS patients. And if you look at the PCI subset of current PCI group, current OASIS, you saw clearly that the cardiovascular death, MI, stroke, and definite stent thrombosis came down with clopidogrel, almost similar to triton, but triton clearly increased TIMI major bleeds, cabbage-related bleeding, and fatal bleeding. So there was still this issue of increased bleeding with prasugrel as compared to current treatment. So the Plateau was basically a study which looked at ticagrelor versus clopidogrel in ACS, looking at efficacy and safety. And this was published in the New England Journal of Medicine on August 30th, 2009. And what it looked at is patients with ACS who came to the emergency room, who were started with antiplatelet therapy, randomized to ticagrelor and clopidogrel, shifted into 3 groups. One is medically managed groups. Number 2, they went into the catheterization laboratory, had an angiogram. We then categorized them whether they went into PCI arm or went into a cabbage arm, and the platelet therapy was then stopped and then shifted onto a cabbage arm. And the loading was aspirin and clopidogrel there at the antiplatelet arm. ACT and ASA and 2B3A receptors were given in the medically managed group, clopidogrel 300 milligram loading, and then compared with aspirin. So a lot of these patients, what we need to understand in the Plateau was in multiple countries, 862 sites and 18,000 patients on the Plateau study. What is main inclusion was hospitalization for STEMI on a non-ST elevation MI and unstable angina with onset during 24 hours. STEMI was also included, but only in groups where primary PCI was planned. It's important that thrombolytic therapy in the last 24 hours is excluded, and this is very important in our subset of patients in our country. And non-ST elevation MI was the standard criteria of 2 of 3 of the following were included. So this is the study design. All patients received aspirin. They were clopidogrel treated as well as naive patients, which were randomized within 24 hours of index event, and then divided and randomized into clopidogrel and ticagrelor. If pre-treated, no additional loading dose of clopidogrel was given. If naive, standard 300 milligram loading dose was given, and then 75 milligram once a day maintenance. In ticagrelor, 180 milligram loading dose, then followed by 70 milligram twice a day, additional 90 milligram pre-PCI, and 6 to 12 months results. Primary endpoints for cardiovascular death, MI, and stroke, and primary safety endpoint was total major bleeding. What is important that we had both clopidogrel treated and naive patients. Additional 300 milligram was given in the clopidogrel arm pre-PCI, and most importantly, all patients received aspirin. So, the difference between Plateau and Triton, if you really look at, was Plateau was in an initial management in the emergency room and Triton was only after the angiography that prasugrel was given to patients. So this was the study design, and that's again we want to reiterate that this is very important to understand that the ticagrelor was given in the emergency room after initial evaluation of patients with ACS. Now the broad group, again I want to categorize this very importantly, that there was no fibrinolytic arm in the STEMI group, and that was an exclusion criteria for the plateau study. While in the non-ST elevation MI group, there was PCI medical treatment and cabbage. So this is what the exclusion criteria was. In management forms, fibrinolytic therapy within 24 hours, oral anticoagulation therapy, PCI after index fluid and before first study dose, and strong CYP3A4 inhibitors or inducers. Disease states exclusion included severe hepatic dysfunction, renal patients requiring dialysis, increased risk for bradycardia, which we'll come to, what happens with ticagrelor, and an increased risk of active bleeding like upper bleed, GI, or hemorrhagic stroke. The baseline characteristics between ticagrelor and clopidogrel were similar. The age group, both had equal number of 75 years, about 25% or so patients were women. And what is important here that about 50% of both groups of patients had clopidogrel, and that was one of the issues which you could discuss during the discussion on the plateau. And also that about 13% on the ticagrelor arm had 600 milligram clopidogrel and 19% on the clopidogrel arm had 600 milligram plus clopidogrel. The invasive approach was about 70% of patients on both arms. 60% of patients had PCI and 60% had stenting in both arms. And the efficacy outcomes, which were basically the primary objective of plateau, which was the prevention of vascular events as death from vascular causes MI or stroke in ACS patients. And the secondary efficacy looked at various issues, including primary composite in subgroups intended for invasive management, cardiovascular death, MI, stroke, recurrent ischemia, TIA and arterial thrombosis, all-cause mortality, MI and stroke, MI alone, cardiovascular death alone, stroke, all-cause mortality, and stent thrombosis. And what was very, very clear is that the difference between clopidogrel and ticagrelor was very clearly seen even at the first 30 days. And if you look at the absolute risk was about 0.6 with a p-value of 0.04. And what is interesting is that the curves continued to spread. And if you look at 12 months after randomization, the absolute risk reduction was 1.9, very significant. And the number to treat was just 54 patients to get the benefit with ticagrelor, with a p-value less than 0.001. So clearly what ticagrelor does over clopidogrel is that it shows a cumulative evidence of reduction of events up to 30 days, and the 30-day spread continues up to 330 days with ticagrelor. Now, if you look at the consistency of benefit of ticagrelor, what you can see clearly is that the primary objective was better, the secondary objective was better, and look at the p-values. Secondary endpoints of all events was better, myocardial infarction was better, cardiovascular death independently was better, and total death independently was better. The only thing which did not show significance is stroke. Now the secondary efficacy endpoints, if you look at in terms of myocardial infarction and cardiovascular death, again ticagrelor was clearly the winner over clopidogrel. The absolute risk was 1.1 in terms of myocardial infarction and 1.1 in terms of cardiovascular death. What about stent thrombosis? Definitely lower on the ticagrelor arm as compared to the clopidogrel arm, both probable, possible, and definite. Now the efficacy was across the patient subgroup, and if you can look at the left side of the graph, you clearly can see that the ticagrelor was winner almost in all subgroups. It did not really depend on body weight, age, presence of diabetes, or in patients with prior stroke. So clearly, unlike prasugrel, ticagrelor showed a net benefit in all groups of patients. Typically also in the invasive and medically managed groups, by final diagnosis, again ticagrelor was the winner. What about safety? Safety was defined both in terms of first time to first occurrence of major bleed, and secondary safety endpoint included cabbage, non-cabbage bleeds, total minor bleeds, and combination of all the bleeds. And again, there was no difference in bleeding complications in terms of time. It was ticagrelor versus clopidogrel. P-value is non-significant, and all bleeds, that is major bleeds, major fatal or life-threatening, TIMI major and TIMI major plus minor, was no different with ticagrelor. The only difference was clearly fatal ICH, that's intracranial bleeds. That was significant, but if you look at for ticagrelor, but if you look at all the other bleeds, the ticagrelor seemed to be a winner, really, though the p-values were at 0.03. So apart from the fatal intracranial bleed, I don't think ticagrelor had any issues. Also, CABG and non-CABG major bleeding was no problems with ticagrelor as compared to the clopidogrel. So in short, in terms of total major bleeding, no difference in total major bleeding. More major non-cabbage include non-procedural bleeding, but no difference in fatal or life-threatening bleeding, but more fatal intracranial bleeding, but fewer extracranial fatal bleeds. What is most important is this issue of dyspnea, which is an issue with ticagrelor, that any dyspnea was more often seen in ticagrelor, p-values significant as compared to clopidogrel, with discontinuation of the drug was also commoner with ticagrelor, but most of these dyspneas were in the mild to moderate category, and the dyspnea did not lead to death in patients of ticagrelor versus clopidogrel. Obviously, leading to discontinuation was more common in the ticagrelor arm as compared to the clopidogrel arm. Dyspnea was reported more frequently in patients with ticagrelor, but did not, as I told you, relate to any events in terms of mortality or in terms of pulmonary function tests. Dyspnea is usually mild or moderate. It usually occurs within the first 7 days with a median time of 23 days, responds spontaneously, and patients with baseline cardiopulmonary were not. So a COPD patient is not at increased risk of dyspnea. And benefit of ticagrelor is maintained in patients at risk, those who experience dyspnea. Patients with mild to moderate dyspnea should be encouraged to continue ticagrelor considering the consistency of benefit. The other real issue is ventricular pauses, and most of these ventricular pauses are at more than 3 seconds and they occur in the first week. The rest of that is not significant. So the rest of the pauses more than 5 seconds and more after 30 days is not significant. There is also no increase in adverse clinical consequences because of the low heart rate. There was a 15% increase in uric acid and 10% increase in baseline serum creatinine on ticagrelor versus clopidogrel, but again it did not really have any major clinical events in terms of outcomes to patients. Uric acid related adverse events occurred very relatively small in few patients, and gout was same in both groups, ticagrelor and. So in the summary, in terms of efficacy, I think it's very important to read this slide carefully. 1,000 patients, if they are admitted to a hospital for ACS and planned for an invasive strategy, using ticagrelor instead of clopidogrel for 12 months resulted in 11 fewer cardiac deaths. That's the number to treat is 91. Similar with myocardial infarction, 11 fewer myocardial infarction, 14 fewer deaths, number to treat is only 71. 6 to 8 fewer cases of stent thrombosis with no increase in major bleeding or need for transfusion. So if you treat 58 patients with ticagrelor instead of clopidogrel for 1 year, you will prevent one event of cardiovascular death, MI or stroke, and you will save 1 life in 71 patients treated. So I don't think this sort of mortality benefit has been shown with any antiplatelet in the last 25 years in terms of total mortality, initial procedure, invasive arm, conservative arm, and in the cabbage arm in terms of hard cardiovascular mortality and total mortality. Thank you very much for your patient hearing.
Thank you, Dr. Ajit, for an excellent talk. Yes, we beautifully analyzed the limitations of various antiplatelet agents and analyzed the plateau study, which has clearly and consistently shown the benefit of ticagrelor over clopidogrel.